working moms.
Hey, working dads.
Hey, aspiring working parents.
And allies of working parents.
Are you in search of your pillow?
Does it take you 24 hours just to get out the door in the morning?
Are you the family ATM?
Or the family Uber driver?
Are you on a Zoom call for work while carpooling while also watching a practice?
If so, welcome to our world, the Parents at Work podcast.
I'm Lori.
I'm Jason.
We are married.
And we have two wild and crazy redheaded boys.
We're here to shine a light on the roller coaster ride that is working parenthood. I'm a healthcare lawyer and founder of a working parent community called Mindful Return.
And I'm an executive coach with Ready, Set, Launch, LLC. I wrote a cool book called Relationships to Infinity.
And I wrote a cool book called Back to Work After Baby. Hello, everybody, and welcome back to the Parents at Work podcast. I am so excited today to be here, not only with my wonderful co-host, Jason Levin, who is always joining me on this podcast, but
equally excited.
Yes, but with the amazing Dr. Lucy Cruz, who, as some of you might know, was my breast surgeon last year when I was diagnosed with breast cancer right around this time of year. And sort of in honor of that 1 year milestone for me of being beyond cancer and having gotten through a big old surgery, I wanted to do an episode both about Dr. Cruz as a working parent and also about early detection. So that's where we're headed with this today. Dr. Cruz, welcome to the podcast. I am so excited to have you here.
Well, Lori and Jason, thank you so much for having me. It's been a pleasure being part of your life, unfortunately for the reasons that we are, but really truly honored that you chose me as a surgeon and that you invited me to this podcast, and it means a lot to me. So thank you.
Awesome. Well, okay. So I want to say that when I first found out that I had cancer, I was a hot mess, as I suspect lots of people are, just like swirling around. What the heck is this diagnosis? And the day that I found out was it was a Friday, and I had had a biopsy maybe 4 or 5 days earlier, and I hadn't gotten the results yet. And I thought that I might have an infection in the biopsy site. So I went to my primary care doctor because I had spiked a fever. And I left the primary care doctor, and they were sending me to the emergency room because it was the end of the day and they weren't able to run the tests. And so I was walking downstairs to the minivan where Jason was sitting, waiting to pick me up to go to the emergency room at Georgetown when I got the call from, I believe, the radiologist who said, "You have cancer." And so I'm like walking across the street, across Connecticut Avenue on DuPont Circle, like to the minivan with in the state of shock. I get over to the emergency room and there's a way long wait list, right? I have to sit in the emergency room for hours. And not only maybe 2 hours after I got my diagnosis, you called. And I'm sitting there and the radiologist said, "I'm going to put you in touch with Dr. Cruz. She's amazing. Like, you'll be great." And I text my primary care doc and she's like, "Oh, I've heard great things about her." And then I just want to say, how are you so human, Dr. Cruz? It meant so much to me that several hours after the worst news I could possibly have gotten, that you were there saying, "It's going to be okay. I got you." So, I mean, just thank you. And how do you maintain that personal touch?
So, Lori, you're going to make me cry because I didn't know that was actually when I was calling you. So I don't know. I feel like I went into this field. I knew that I wanted to be a doctor since I was a very small child. I was 5, and I would dress up as a doctor and tell my parents I was going to be a doctor, and I knew I wanted to take care of patients. And I then knew that I wanted to take care of women, but I didn't know in what capacity, and I didn't know about this field of breast cancer surgery. And I kind of not really fell into it. I don't believe in falling. I believe that there's fate. I believe that there is a book of life, that my name is on it, that your name is on it, that Jason's name is on it. And there's a beginning, the end, and things are written that are like the large, kind of end of the big things in our life. And I think that this was really something that, kind of felt like I felt like it was something that was like my original purpose. And it was my part of my original design. I was built for that. And so, when you do something that is really part of who you are as your soul and your human part and your spiritual part is like kind of meets where it's supposed to be in a place and time, it all comes natural. And I think I don't forget that. I don't forget the blessing that it is for me to be able to touch women's lives. I don't forget that I could also be be a patient in my lifetime. And, I've had people that I love be patients. I've had people that I'm friends with and that I've known for my whole life to be patients. And, my dad was a patient, even though he wasn't a cancer patient, but he was still a patient in his last several months before he passed away. And, I kind of always go back to that, even when on days that I'm struggling to really be 100% present because I'm juggling mom, I'm juggling work, I'm juggling like all of these hats that I carry and I put on and off. And sometimes I have two of them together or three. I kind of remember that when I do talk to patients, I am there for those 5 minutes, 10 minutes, 15 minutes, and I try to make the best of that time and that moment that I'm touching their lives. So, if I have a chance to call you on my cell phone while I'm driving to go pick up my kids and make that change and that difference for you, it takes 5 seconds. And, I always tell people like, there's not much that you need to do. I tell my kids this, like I say, you don't have to do much to be great. You just have to be 1% better. And I remind that myself. I just have to be 1% better of yesterday version of Lucy to be able to give like to my patients, to my children, to my friends, to my family. And so that's what I strive for. I just, I think that, I love what I do. And then I have this vision that I could always do better. And so that's really like, there's no really thought process to it. It's just really trying to change people's lives in a positive way when I touch you. Because I know that, the cancer journey is not an easy one. My mom had breast cancer last year. I've had, like I said, I've had friends and I've taken care of hundreds and thousands of patients with breast cancer. And so I feel honored and blessed that I'm able to do this day in and day out.
Well, that it shines through in your care for your patients, Dr. Dela Cruz. And the other thing that I felt was sort of like written into the story was when 5 days before my surgery, I went to the We Can Do Hard Things book tour in Northern Virginia and stood up and asked Amanda Doyle a question because she's the one who had breast cancer, which motivated me to go get the screening. And she comes down out of the audience and gives me a hug. And at the end of the show, she said, I know it's too late for you to change anything given your surgery's in 5 days, but who is your surgeon? And when I said it was you, she was like, oh, thank God. And she was just so happy to know that I was in good hands. And so I think those two things, like having you call and then meeting Amanda and then running into her at the plastic surgeon's office after the surgery, were all just things that made me say, okay, like there's something protecting me here. Like I'm going to be okay. It's good not to be alone in these moments.
I think that that's part of life, when you are in the right, mindset, you see those signs. A lot of people have those signs come to them and they're unable to see it. But I think that shows a lot about you and being open to those signs from the universe. So that's beautiful. I think that has allowed you to have
always on the
one of those
lookout.
eye-opening journeys. Yeah.
Every day is a new adventure. Indeed. Jason, over to you.
And as we talk about the universe, about a week before the surgery, my therapist, who I won't name, admitted, I had Dr. Dela Cruz for my breast surgery. So I was even more comfortable.
Oh my God.
So
that I did not know. Oh my God.
Yes. So there's like this whole circle of Dr. Dela Cruz. And so I was nervous and yet oddly comfortable with all of these things that were happening. So thank you for being you. You had said something really interesting as you were growing up. I'm curious, where did you grow up? And this idea of being a doctor that you were talking about as a child, what kinds of things were you doing to pursue that interest even as a kid?
So I actually am Cuban. So I was born in Cuba. Both of my parents practiced medicine. They're doctors. My dad passed away, but my mom and him met in medical school. And then my dad was an immunologist, and my mom was a biostatistician epidemiologist. So they met in a lab doing research when they were like 20 years old. And when HIV broke out in Africa, my dad was a prolific scientist in Cuba who had done his thesis for his PhD on CD4 cells, which in 1973, nobody knew what CD4 cells were. And my dad was one of the few people in the world that had done a thesis for his PhD about this cells and the mechanism of HIV incorporated CD4 cells. So when they were building the team of people that were going to investigate HIV in Africa, he was one of the people that were brought in by the UN. And then my mom did biostatistics. And this was the time when statistics were done in little cards. And I remember having like a huge IBM computer, which is a room with an air conditioner, the only room in the lab in Africa with air conditioner. It was for this computer. So she went there with the World Health Organization. And so when we arrived in Africa, I wasn't old enough to go to school. So I spent my first year in a lab in Africa with HIV samples and patients. And so my mom made me a little white coat, and I would just like write fake scripts and hand it to the patients who would come in. So it was a site of testing. So they would have patients come in, get tested for the Western blot for free because people had AIDS, but they weren't diagnosed with HIV. So that, I mean, that was where I I remember I have vivid memories of that time. And, you know, I remember like seeing kids with something called Kaposi sarcoma, which is for advanced HIV or advanced AIDS from women who had given birth they had AIDS, they gave birth. So there was a neonatal HIV. And then these kids were untreated and had really a lot of progression of disease, even as small children. And I remember like vividly saying, I'm going to take care of women when I grow up. I'm going to be a doctor. Again, I didn't know like in what capacity. And so, you know, we lived there till I was 10 in the early 90s. When I was older than that, in the early 90s, I'm kind of trying to pretend that I'm younger, but in the early 90s, we went to Spain, and that's where we asked for political asylum. Yeah, I'm 26 for life. And so we asked for political asylum in Spain because we were being persecuted by the Cuban government. My parents were, because they defected they're you know, part of the country and communist, you know, being representatives of the Cuban government outside. It was considered treason. So my parents defected. We asked for asylum in Spain. We waited about a year and a half. We got our visa to come to America. And then we came to the US. And I continue with like the idea of wanting to be a doctor. So I studied really hard in school. I didn't know English. So I went to English as a second language my first year. I cried every day because I wanted to pursue like advanced math and advanced science. And I was like, Mom, I just don't know how to speak English, but I do know math and I do know. And so I was very frustrated my first year in school because I wanted to do better and I wanted to be the top of my class. And I knew that I couldn't do it in that controlled and like more limiting environment, to be honest. I felt very limited in that environment. So the second year, I took my TOEFL during the summer to prove that I could speak English, even though I didn't speak English. So I just got a thesaurus and a dictionary, and I learned all the words. I went and took this test, and then I started school without knowing how to speak English in all English class. And I remember going home and like not answer. And me, I'm, you know,
Wow.
Lori and Jason, you guys know I talk a lot. So for a kid who talks a lot, who can't speak the language and then can't ask questions, can't comment the answer at school, was very frustrating. So in 3 months, I learned English. And then I went on to obviously graduate from high school. I did really well in high school. I was valedictorian. So I kind of pushed myself. And then I got a scholarship to go to UM. And my first semester, I said, I want to go. I was younger. So I graduated younger from high school. So I was in college and I was 17 and I was like, I want to go to do medical missions. I want to go somewhere else. And like, cause I still have time. I'm young. And so I went for a semester abroad in Dominican Republic and then I stayed there. And, I figured I didn't realize how hard it was going to be when I came back to America to say that I wanted to be a surgeon. And, when you're an international graduate who comes back and you want to be a surgeon, which is one of the most competitive fields in medicine, as a foreign medical graduate, it's like, you have like the trifecta. It's like the antidote to becoming a surgeon. So like, first of all, being a foreign medical graduate, second of all, being a woman, third of all, being Hispanic, and fourth of all, being an immigrant. Like if you wanted to combine all the odds and like put them in this place where you are likely not to succeed, that's what
It'd
I
be very
had.
low. Yeah.
It's like, listen, your chances are like, you might as well just play the lottery. And, I pursued this for 6 years. I did research. I did all sorts of free jobs in medicine to be able to get like letters of recommendation and to be able to even get an opportunity. And when I got an opportunity, I always tell people that, many doors have closed in my life, but the few windows that have opened, I've known how to jump through them and really made the best of them. So I got this 1-year opportunity as an intern in surgery, and I worked really hard. I worked the hardest. I was there the first, the last to leave. I committed to it. I knew people that had given me the opportunity above some other people. I felt like I needed to honor that, and I couldn't let them down. And I put that in my pocket and I ran with it. And then I got a second year, which was a categorical. So that's kind of like the way that surgery goes when you're a foreign medical graduate. You get a prelim spot where you pretty much just go for 1 year. And then if they like you, if you do really well, only like 15% of people get offered a categorical spot. And again, like, it's very hard. I'm saying, it was a very competitive position. So one opened up and there were 20 people like that would have been candidates for it, and they gave it to me. And so I worked really hard again. And then I got pregnant during residency, and there was no maternity leave during residency when I was a resident. And your maternity leave is really pretty much your vacation time. And, when you're a fourth year, I was a fourth year, so it's 5-year program. You have to preserve your vacation, because if you get sick, that's where it comes from. If in order to not delay your graduation, if your baby gets sick and you have to take care of your baby, you have to take away from your vacation, so that you can graduate on time and you can take your boards and then you can go to fellowship. So I get pregnant during my fourth year, and I was like, oh my God, how am I going to do this? Like I don't have maternity leave. How am I going to leave at home a baby?
Yeah.
Who am I going to trust the baby with? My mom couldn't take care of the baby full time. My in-laws couldn't do that either. It was, my ex-husband was working he was working. So I was like, we have to figure this out. And so I remember they were like, well, you have a total of 4 weeks. But if you burn through those 4 weeks, then actually no, I was pregnant during my 4th year, but I was going to be giving birth at my 5th year, which meant that I really only had 4 weeks. That's why I was. And I was like, well, if you use up your 4 weeks for maternity leave, if something happens with you or the baby, then you have no time. And then I had already like applied for my fellowship, and I was going to be late and they may not hold my spot.
Fellowship, yeah.
So I essentially took 2 weeks of maternity leave. And I went back to work, and I left my 2-week-old baby at home. And then, anyways, so that's how I got here.
Wow.
That's it. I'm not gonna belabor on that, but that was very traumatic for me. Let me tell you, those 2 weeks of maternity leave, and leaving a baby at home.
Like you've just
had a baby,
and the physical healing is like nowhere near done after 2 weeks. Yeah. I will insert one statistic here, which is that 25% of people in the United States go back to work. 25% of new mothers in the United States go back to work after 2 weeks. And so I wish that were like, oh my gosh, so rare. But a quarter of all women go back after 2 weeks. It's such an awful system. But go on.
No, I mean, that was the sad part about it, that I missed out on that. Go ahead, Jason.
I'm just so impressed by your drive, your motivation, your resilience, you say you want to be a doctor. your parents are doctors. You're growing up in this environment where dinner conversation is probably in and around these topics, and you see all these barriers, and you're like, hold my beer, I'm going to do it anyway. And so, one more question before I go to Lori. Where do you believe this inner drive comes from, where you don't give up? You follow through to its most natural conclusion and then some. It's like you're the Energizer Bunny and a doctor. So what's the inside? What's continuing to propel you? That's fascinating.
Failure. Having failed many times. It gives me the drive to continue to try on and again till I succeed. So I tell my children that I've learned more from failures than my very few successes in life. I have failed many times, many more times than I have time to talk about. But I definitely feel like what you see is the success that hasn't come without many failures. And I think it's not that failure doesn't affect me, it affects me. I mean, I'm human, and I think I can't tell you that it hasn't been all roses. It's been tough. There've been moments of self-doubt. There's been moments of, frustration. There's been moments of potentially even thinking about giving up and going and saying, I'm going to give up, and then coming back to it. And so I think it's been a messy process. I mean, my perseverance is pretty, I mean, the older I get, the more I now welcome failure. I think when I was in my, 20s, failure drowned me in a lot of places, and I just continued on, and I was like, okay, this is not a defining thing. I cannot be defined by failure. I will continue to do this even if I know I'm going to fail again until I succeed. And I think it's also a little bit of stubbornness. My first grade teacher wrote in Spanish. Lucy is she wrote it in Spanish. It was like terca al punto de, I'm trying to translate it, but it was like, I am stubborn to the point of endearment. And I don't know if I take that as a compliment. But I think there has to be some.
That is a great line.
Like stubbornness. Stubbornness to the point of endearment. That's what she called me. And I think I think she saw a glimpse of my stubbornness, but also my drive to be able to continue to pursue it, even when people that I love told me to quit. I will tell you, I've had people in my life that have, people come for a reason, seasons, and I have few people in my life who I can pinpoint at certain points in my life that God or the universe put in my life to be my cheerleaders. And my dad was one of those that was a long-lasting cheerleader from when I was a baby, and I can remember him always being a cheerleader. And I had a partner in my life who at some point was my cheerleader when I needed that, when I was in my 20s. And then, and now what I'm trying to work on is being my own cheerleader. And I think that combination of like stubbornness with ability to not have external validation and reaching this point in my life where I'm a little older, I'm a little wiser. I've now embraced failure and I've embraced success, and I enjoy some of it, all of it, some days, not all every day. But really realizing that failure and success are really in a moment in time. They're not really like, they don't last as long as you think they do. They're actually pretty finite. So you enjoy when you succeed. You don't dwell on the failures. You just, And so I think that's kind of what today I feel like I can verbalize it. I don't think if you would have asked the 24-year-old me, what drives you? I would have been like, the fact that I don't know where I'm going to do. I don't have any money. I mean, I think that those things, but now I realize that it wasn't that. I don't think it was that, because a lot of things there were easier ways out. There were a lot of paths that would have led me to have a salary, that would have led me to have, a job. And I think that ultimately when I look back, it's really like that ability to realize that I could overcome failure and succeed eventually, eventually, right? So yeah, that's what it was, Jason.
Yeah.
Sorry, that was a
Yeah. And
belabored
it's,
answer.
No, I love the answer of endearing stubbornness. In 2026, that's called leadership. So, and I think Lori has a question on your leadership, but that's clearly what you've been able to show is that you have this failure tolerance. You know, just like we asked to do one more push-up or one more plank, and can you flex that muscle? You've got this failure muscle that's almost like a bodybuilder, size. So it's leadership. So
you.
go ahead.
failure
Lori, on your
muscle.
question.
Yeah. Yeah. No, I have a million questions, but I do just want to appreciate and take a moment to reflect on like the fact that you have thought a lot about the perspective that you have right now. And it's very clear that you're not just like mindlessly going through the decades. Like you appear very intentional about it, which I really appreciate. I'm just curious, like go back to the early mom years. Did your second, you have two boys, right? And did your second parental leave go any longer? Jason and I also have two boys, so we have that in common. But how did your second leave go compared to the first one?
So I commuted. So I got pregnant when I was working at Penn. I was already faculty, and I was commuting from DC to Pennsylvania every day. And I was commuting about 6 hours a day.
Oh,
Wow.
And this was, one of my dream jobs. And so I was married. We lived here in DC, and we weren't moving. So I figured I can do it. And so I did that for 3 years. 7 months I was pregnant. Well, 8 months because I took off. I actually quit
Wow.
my job right when I was supposed to go on maternity leave. And I said, listen, I'm not coming back after maternity leave. I think that story is for another day. But at that point, there was a lot of misconceptions about if there was maternity leave available or not. Anyways, ultimately, they gave me maternity leave and then I quit. And so I took the 3 months and then I started a brand new job. And let me tell you, I remember I cried during my maternity leave because I realized how beautiful it was and how much I loved that experience and how I missed having that with my first son and how I felt cheated for not having the ability to see, like, to be with him and smell him and like feed him and like just cuddle with him and like allow my body to connect with the baby and for my body to also heal and my emotion. I mean, 3 months is not enough, I think, emotionally for women to heal, but like at least it was something. And I think I realized what was taken from me before. And I must say that I felt like a little bit of sadness because I felt something had been taken from me. I felt sad for my son who hadn't had me there when he was a baby and somebody else was cuddling him. Somebody else was nurturing him when I should have been there. So there was a little bit of guilt, a little bit of anger. There was a lot of emotions, I think, at that time. And I remember vividly like that moment where I held the baby and I was like, I didn't do that with my first one. I didn't get to do this with him. And therefore I was even more intentional during that time to enjoy every moment of it. Like I can't tell you like how incredible for me those 3 months were of just knowing that I was able to do it and I was unapologetic about it and I didn't want to hear anybody telling me otherwise and I could care like anything's. If anybody said that my career, I was like, you know what, this is the time for me, for my kid. And then I started a new job at Inova. That's when I couldn't do this commute every day. And I was like, I definitely can't do it with a newborn because then I knew that I was going to again miss out on all these things with my kid. And then also with my older child who was already 5 and I had missed out a lot commuting 3 years.
Right.
And I had already missed out before that in training and with no maternity leave. So, I that time when I realized that I wanted to be a more present parent. And I was like, I think this is when I'm going to, Lucy, I called it the Lucy 3.0. Like Lucy 3.0 is going to have the balance that she wants to have. Well, the balance. But I realized that I had missed out on that. And for the last 6, 8, 9, 8 years, 8 years of my life, I didn't have balance. And definitely I didn't have balance as a parent. I was really skewed towards like my career, and I was, I worked a lot more than I was a parent. And at that point, I realized that I needed to shift, and I didn't want to miss. I kind of had an intervention for myself and said, okay, like this is what I'm going to do. I'm going to focus on being like a good mom and being a present parent, and then if life wouldn't have it, that's when I started my divorce process. So I really, at that point, I was like, okay, great. So I'm going to be a new mom, like a different type of mom, not a new mom, but I'm also now going to be a single parent. So that was what, like, then I think,
Wow.
I think at that point, I had a different view of life. I think those 3 months being with the baby, that I realized that not even divorce was gonna like shake my ability to parent. And I think that that's what, like, that not having it and then having that ability to parent and being present, even like with an external thing happening even at home, like an emotional thing, I embraced my children. And I remember, like, I had a therapist at that point, Jason, and he said, I think you're like, what you're doing is crazy. And I go, what do you mean? He goes, well, you're just like moving through things like, you and you're co-parenting. Like if you've been co-parenting for 6 years, like what you're doing today after like a month of like getting separated is what people take 5 years to accomplish. And you're doing it today. He's like, this is crazy. And I go, well, you don't know me, but there's a little bit of insanity here. And I think for me, it was because I didn't want to take that away from my kids. Like you're going through all these emotions. Now your family is broken. And what I didn't want is to have my emotions impact my ability to parent, but also impact my children, because I felt already guilty that I had done that for 5 years with my other kid while I was working. I was like so driven with my career. I was like, there's no way I'm going to let anything or anybody ruin this moment in time. And it's not going to get in my way of loving my children, of like hurting them or bringing all of this negative energy that I'm carrying because I'm heartbroken, because I'm devastated. I'm not going to do that. This is going to be the time where I need to show up for my kids. And again, failure, Jason, another failure, right? So like my marriage has failed, and I don't allow that to define me. I said, you know what? If I'm going to do a divorce, I'm going to do it the best. It's going to be the best divorce. And I'm going to just co-parent from today. We're going to co-parent today. Today we're starting co-parenting today. We're not going to take years. And because I figured that my children were going to suffer from that.
Not going to wait around. Yeah.
I mean, and it was hard.
Yeah. And
go ahead, Lori.
And you called an intervention for yourself. You became a more present parent. You got your way through this whole divorce. And as many people might think, okay, well, if you decide to be a more present parent, then that means your career is going to slide. And like, for the record, you just got this big old promotion and are the system lead for breast surgery for all of MedStar Health. So I just want to point out, like, I don't think that's a coincidence. I mean, like, tell me more about how we can lean into the idea that we can be amazing, more present parents and have a successful career.
I think one of the things that I think it was the Pepsi-Cola CEO or Coca-Cola CEO, she said, you can't be 100% everything all the time. And so what I try to focus is, when I'm at work, I don't feel guilty about being at work. When I'm at home, I don't feel guilty about not paying attention to work. And when I'm by myself, I don't feel guilty about not being a parent, and I don't feel guilty about not being at work. And I think I talk to patients on the phone at home, but I don't bring notes to home. I don't bring upset days to home. And if I have a bad day at home, I don't take it to work. If I have stuff that I'm dealing with at home, I don't take it to work. So I think there's this ability to like put in a drawer for the time. And again, this is all part of my process that I've worked with, like myself, kind of knowing where I have the ability, things that I naturally did as a kid, now I'm using them to my advantage. And I think that that's one of the things that I do. I walk home from work, and in those 7 minutes that I have of walking, I leave it there. Whatever I'm going through, I leave it there. I listen to music. I go, those 7 minutes are my minutes. I'm going to leave. If I'm pissed off at work, or if I'm like struggling at work, or if I'm frustrating at work, if I've had a horrible day at work, or if I've actually had an emotional day at work, because I do have very heavy days sometimes, I leave it there. That doesn't make me a bad doctor because I don't care about patients. No, it's just because I can't bring that here. And when I come home, I focus on what's going on here.
Yeah.
And, sometimes when I get home, I tell my kids, I'm going to take a shower.
How old are your boys now?
12 and 7. How old are your boys? I think, are they how old
12 and 7.
Yeah.
Ours are 13 and 15.
Yeah, so they're like teenagers. So there's a different beast there. I'm not
So
ready
just a little bit ahead. Yeah.
So when I get home, I take a shower. I go, listen, I'm going to go take a shower.
They're broad shoulders and deep voices.
Yes, and a lot of emotions.
Yes.
And my 12-year-old is reaching that point of broad shoulders, and
Yes.
So so I just try to disconnect, and I try to compartmentalize.
And the listening to the voice go down is
So
amazing. I want to shift gears, if that's okay, into talking a little bit about prevention and awareness. And okay, so Dr. Dela Cruz, I have a little story for you. I got a mammogram that said that I have dense breasts, and then it had the little asterisk at the bottom that said, therefore, because you have dense breasts, the results may be inconclusive. And the first 1 or 2 times I got the mammogram, I just sort of left it at that. Later, I come to learn that there's this ABCD thing going on with breast density. And recently, I talked to a friend of mine who lives in France, but she's American. And I said, did you know that there are these categories for breast density? And she said, yeah, it's on my report. I know I have category C. And then I talked to a woman who's in Canada, and she had her first mammogram. And I said, did you know that there are these categories for breast density? And she goes, yeah, it's on the report. I have a B. And I was like, how does the whole world seem to know about this ABCD thing, except those of us in the United States? What's going on there? And can you explain it to us, please?
We report it a little bit different. So we report it now with an ABCD, although it's still defined as the same. It's either fatty, fibroglandular changes. So fatty is A, fibroglandular changes is B, heterogeneously dense is C, and extremely dense is D. It's just that we use the wording. So 10% of women are fatty, 10% of women are extremely dense. 40% of women are fibroglandular changes. 40% of women are heterogeneously dense. So 50% of the population is considered either heterogeneously dense, meaning C, or extremely dense, meaning D. And those are the patients where, in instances, mammograms, in about less than 10% of the time, they could actually not be able to see some small cancers because of the density that happens in the breast. Now, the new guidelines are, first of all, the task force about 1.5 years ago actually came up and said, oh, yeah, you know what? We should do mammograms starting at 40. So all women should start screening at 40. This wasn't always the case. The task force is really what like Medicare and a lot of the insurance companies, like HMO companies, for example, or health management organizations, they were abiding by that. So women were in HMO companies were not getting mammograms till 54. But now that the task force said, oh, actually, we should do 40, then now in the last 1.5 years or so, they have now moved the needle to 40, which is the correct thing. And I think in the future, potentially even minority groups may get screened younger. Again, I'm not saying this is not here. You heard it here first. I'm just saying because this is a topic of conversation and an interest. Now, the breast density is reported. It's just not reported the way that it is in other countries because we don't put ABCD. We just put, but a lot of patients don't know what that means, right? They're like, well, heterogeneously dense, fibroglandular changes. Right. I don't know what that means. So if your mammogram says heterogeneously dense or extremely dense, you definitely need to see your provider, either a GYN, your primary care physician. They may refer you to a breast specialist. At that point, they will do a calculation, which a lot of the radiology departments are now doing, which is called a teracusic. if you go to Georgetown or MedStar, they will do a teracusic when you come in for your mammogram, meaning they will put in your height, your weight, your family history of breast, ovarian, if you've had any previous breast biopsies, the density of your breast, and they will calculate that and give you a score at the bottom of your report. And so they'll tell you your lifetime risk is X. And if it's considered high, it'll tell you a phone number to call, usually our high risk clinics, for you to come and see a provider. So a lot of the radiology groups now that have high risk clinics and have high risk programs like ours at MedStar, they will do that because a lot of patients will read it and won't know what that means. And they will incorporate the teracusic score too, so that they are able to assess if they're elevated lifetime risk and if they need an MRI, if they need now with contrast enhanced mammography, right? Do they need additional imaging? Do they need an automated breast ultrasound? So these are things that are really truly being in now in a lot of the large academic institutions. Most mammograms report density. They should actually by law. And then they will also give you the options for high risk versus, additional information. But yes, I mean, it is reported. It's just very different. The way that they report it.
In my instance, in my case, the only risk factor I had was density.
Breast.
Like I had no family history. I had no other risk factor. I just had extremely dense breasts, and boom, that was the thing. In fact, I mean, I was joking that I thought that maybe by breastfeeding my boys for 2 whole years, that would, have reduced my risk or something. But apparently it didn't.
So I will tell you, 95% of women.
The fact that I was going to get cancer anyway.
So 20% of women have family history. The rest don't. So 80% of our patients who come to our office don't have a family history of breast cancer. None. They're like, what do you mean I have breast cancer? Nobody in my family has had breast cancer. Only 5% of the population has a genetic mutation when they're diagnosed with breast cancer. 5%. So you think, well, I don't have a BRCA mutation. I don't have a family history. I'm not going to get breast cancer. That's not really necessarily true. And I think, I just told you 50% of women have either heterogeneously dense breast or dense breast. And I think that that's where in the next several years, guidelines are going to be more specific and more clear into what do we do. Now we know with the extremely dense breast, everybody should get an MRI for screening, additionally to their mammogram. But then there's that 40% patients who have heterogeneously dense breasts. And I think AI and radiology is going to help. So AI incorporated into your breast imaging, AI incorporated into your assessment of your imaging study, that is going to help us determine, okay, from that heterogeneously group of patients, who is the person that needs an MRI? Who is the person that could just...
Which ones?
And I think because they're going to quantify, they're going to quantify better density. Density is like beauty. Beauty is the eye of the beholder. That's how density is reported on mammograms. Today, the density is really based on visual inspection of the mammogram by a radiologist. But I think when AI comes and quantifies it, we're going to be much more quantitative to say, okay, this is the patient population that needs an MRI every year. But we're not there yet. Again, if you're 40, you need a mammogram. If you have extremely dense breasts, you need an MRI.
Got it.
If you have heterogeneously dense breasts, you should see a provider so that they talk to you, they counsel you, and they tell you what you need aside from a mammogram.
Super helpful. Super helpful. The other thing I wanted to make sure that I mentioned in our waning moments here was what I ended up having done, right? Which was I had a double mastectomy that was nipple sparing and had a deep flap reconstruction. And so I just wanted to have you talk for just a moment about the option of nipple sparing, because that was really important to me and I didn't really realize how important it was. And then also just, what is deep flap for those who might be listening who aren't aware of that particular type of surgery?
So for women who, so obviously breast cancer patients in most cases may have an option of a lumpectomy or a mastectomy. Patients who have a mastectomy, or want to have a mastectomy have options. The oldest technique has been skin sparing mastectomy. Well, not the oldest. It used to be first that they used to remove all the skin. This was Halsted. Halsted was the father of breast cancer surgery. This was done in the 70s, and it was just a massive surgery. They would remove the chest wall. They remove everything. Essentially, it was a very mutilating, horrible surgery that would leave women potentially debilitated with arm mobility issues, lymphedema, and obviously disfigured.
Wow.
People, cancer physicians notice, well, patients are still their outcome is not different. Whether we remove all of this, their cancer is still coming up. And it's really because we realize that systemic therapy, meaning the people that need chemo should get chemo. The people that need the estrogen blocker should take the estrogen blocker. That is what treats the cancer. The surgery is a local control technique. And so there was then the thought of de-escalation, meaning let's do less. I think this dramatic surgery is too much. So then they did something called skin sparing mastectomy with a sentinel lymph node biopsy. Before removing all lymph nodes, now we're going to sample some of the lymph nodes. And that happened between probably the 80s and the 90s, where we had data that said, it's safe to do a lumpectomy. It's safe to do sentinel lymph node biopsy. It's safe to leave skin. And then if you think about it, in Europe, and actually in Asia and Japan, in the 1990s and 1980s, they were doing nipple sparing mastectomy. They were preserving the whole skin envelope. Essentially, it's almost like removing a letter from an envelope. You leave the skin, all of the anatomy outside of the breast intact, and you just go from underneath and remove everything from within. And in Italy, the Milan group, the Veronesi group, they were the first ones that started saying, hey guys, I think this is safe. And they had long-term outcomes showing feasibility, safety of nipple sparing mastectomy in the setting of breast cancer. They first started picking patients with small tumors that were very far away from the nipple, thinking that, that would give them safety, and then pushing the envelope a little bit more and a little bit more. And today we have robust data to support nipple sparing mastectomy. Now, nipple sparing mastectomy is only done by 5% of the breast surgeons in the country. It is not done in a lot of institutions. It is not even offered to patients in a lot of institutions because it is a specific skill set. And what I'm talking about skill set is the ability to do this proficiently. It's like and I compare it to it's people think, well, it's just breast surgery. Well, it is a complicated surgery. It's a lot harder. And it's almost like if you're going to go have a liver transplant or a pancreas surgery, are you going to go to the person that does one pancreatic surgery a year or one pancreatic surgery a month? Or are you going to go to the surgeon that does it every day? Of course, you're going to go to the high volume centers.
No.
Right? And so
that
is the difference. And so I think it's just ability for patients to go to a place that is considered a high volume place for nipple sparing mastectomy. So one of the things that I tell patients is ask them, how often do they do in a week? How often do they do a nipple sparing mastectomy? How many have they done? What are their outcomes? Their own outcomes, not the ones from literature. What is your nipple necrosis rate? What is your skin necrosis rate? What is your surgical site infection? But those three things are the most important things. I think nipple necrosis and skin necrosis rate, and also how often are you able to put an implant right away? That is a tall tale. Is it tall tale? If somebody puts tissue expanders, I'm not saying that that's something, but that's
a tell. Yes.
Tell. So if they are doing direct to implant, that their nipple necrosis rate and their skin necrosis rate is probably low. If they're doing immediate reconstruction, meaning you don't have to put a tissue expander and then come back to do the final reconstruction, that means that is a place that they do this often, that they do it well, and that their outcomes are good. Because otherwise, they don't put immediate reconstruction. They don't do the deep right away. They don't put the implants. They do tissue expansion, and then you can have the second surgery. They don't do stage surgery. So I think it's one of those things that people don't know what they don't know, but it's truly a very important conversation to have. And fortunately, only 20% of the country does immediate reconstruction, meaning 20% of patients go to that are going to places where they are able to be offered that because they are able to have good outcomes and it's safe So it's not safe because oncologically it's not safe. It is not safe because their complication rates or their care, they're unable to perform the surgery to that level where they can do the immediate reconstruction. I know this is not going to make me very popular, but that is the honest answer here. And so when I tell patients to go to places, it's places that they are high volume, that they're doing this often. When we talk to patients about reconstruction, there are two options. And the one that you had, Lori, was the deep inferior epigastric pedicle, which is essentially abdominal fat that we remove from kind of like a tummy tuck, but we take it with a vessel, which is the deep inferior epigastric. That little vessel is removed from the abdomen and connected to a vessel in your chest. Now, what that gives you is the ability to connect, provide blood flow to this subcutaneous fat that's removed from your abdomen, allow it to, stay alive. But also it gives you a more natural feeling where patients, when they gain weight, they can gain weight in their breast, and they lose weight, it'll lose weight. And also it'll have the sensation of your own breast tissue. Now, it is not breast tissue. So I have some patients that have it and they're like, well, do I need a mammogram? Because I feel like, no, that's not breast tissue. It's abdominal fat. So usually that's a different texture of breast. And so normally what happens is that in order for you to have it, you have to have had children. If you've not had children and you're planning to have children, we don't recommend that because you can get a hernia when you get pregnant. And usually if you've had children, then your belly has stretched. So you have a little bit of extra skin, that you can actually remove, because it doesn't mean that you have a lot of fat. It just means that your skin has to be able to, close. So as long as you have that ability to be able to
I didn't realize that, so I'm now thankful to my boys.
If you've had children, your skin, because you're pretty thin. I mean, but you had that little thing that we all have, like when we have babies, your belly is a little softer than before they had children. And it's not really your belly, it's your skin that is more lax. And so that gives the plastic surgeon the ability to close that from the area that they removed it and take some of that subcutaneous fat, even if it's not much. But the skin is the one that you need to make sure that it closes to be able to reapproximate it. And it's a little bit a longer procedure surgically, but ultimately it lasts usually, obviously your whole life. You don't have to replace it. You don't have to put it, exchange your implant or anything like that. So that's what a deep is. So.
Yeah. I'm absolutely amazed. Yes. At how it worked out for me, and that I can actually feel sensation in my breast is just amazing. Great. So really grateful to you and Dr. Fan for teaming up and doing that. Okay, so this has been such a delight, Dr. Dela Cruz. Jason has one final question for you before we part today.
I've just been so impressed with the depth of your evolution, your perseverance, this joyful stubbornness that you bring, this comfort level with failure and bringing yourself back. Clearly, you're a very reflective person. What advice would you give to your younger self as we close this conversation out?
Never to settle. I think I in my younger self, I settled in things that I probably knew and deep in my heart that I shouldn't have, and I just did it because of fear. And I would tell myself, don't be afraid, just go for it. Just ask for what you want, speak up, and be more gentle with yourself. Don't be so harsh. But I think ultimately, if I say that, I say that and I don't, because I think being this very inner critic of me that is demanding of myself is really what also drove me to that stubbornness. But I definitely don't settle and definitely don't settle because of fear. There are things that it's not that I regret, but I think I did them out of fear, and not that I don't have fear now, but I now realize that sometimes that's just fear of the unknown. Sometimes is normal and it's natural. And it's not a sign of warning, but a sign of it's a natural evolution of what happens when you don't know what to expect. And it's a natural response. It's not really something that you should make you stop you from doing something that you really want to do, you stop yourself from doing. So yeah, I mean, I think I would say that. When I graduated from high school, one of my front door neighbors, she probably has no idea that this meant so much to me, but gave me a card that I still have that says, "Avoid the great temptation, settling for too little in life." And I thought about that many times, and that's what I think. I got that advice when I was 17 and I didn't hear it. And that's what I would have told my younger self when I was 17. Read that card and read it over and over and over again. And remember, avoid the great temptation, settling for too little in life. I got the message from God and the universe, and I didn't see it. So that's if I had a time machine, like what is it? The movie one with the kid. Anyways, I would Back to the Future.
Back to the Future.
Back and say, Lucy,
DeLorean.
read it again. Read it again. Read that card. So anyways, thank you guys. This has been a
Dr. Dela Cruz, you are inspiring and brilliant and so good at your career and your job. And it's just been such a pleasure to talk to you. Thank you for making time for this. And thank you for everything that you've done to care for me and my cancer journey.